to a patient who is already on sulfonylurea, will it increase the chance of developing hypoglycemia? Should we reduce the dose of sulfonylurea? I actually forgot to stress upon this particular aspect because of the we are running short of time. It's a very important question actually, Janandu. Absolutely. See, you don't find hypoglycemia with SGLT2 or the DPP4 inhibitors. But when you find hypoglycemia with SGLT2 inhibitor, that gives you an impression that the patient is on either sulfonylurea or insulin or both. So it's the evidence-based medicine says all the time reduce the dose of sulfonylurea, or best is to take off sulfonylurea, and in the insulin, if it is used concomitantly with the DP4 inhibitors, either you decrease the insulin units or else the patient will definitely land up in the hypoglycemic episode. Per se, the culprit here is not the SGLT2 inhibitor. The culprit is the sulfonylurea or the insulin. So this is a very good question actually. And of late, yesterday's update I would like to tell you, and it says when the patient is on insulin, you just please withdraw sulfonylurea. That is the latest research output as recent as 24 hours from now, I think. Yesterday, the same time, I just had gone through that. So it says when you initiate insulin, please take off sulfonylurea and then only initiate insulin. This is all to say that you don't let your patient get into hypoglycemia. This is all from 2010. The ADI has taken it very seriously. Earlier, prior to 2010, actually, the ADA used to say you should welcome hypoglycemia because you can reduce the dose. That was even the UKPDS time also. The landmark trial, the United Kingdom prospective diabetes study, still going on. We started in the year 1977 and 87, 97. After 20 years, they had a sitting, and now it is the 2007, 30 years, and now 2017, 40 years. UKPDS is still going on. And from 2010 onwards, when it went on retrospectively, the 600 experts went through the old data. They were shocked to see that the hypoglycemia had miserable outcomes. The patient may get into, like if the patient gets into L3, he may get into the first thing is the metabolic seizures after coma. The second this thing is metabolic seizures, and you may land up in either the heart attacks or the paralysis or the dysarthria, or finally you may not come out of the coma. So the patient, we may lose the patient. If the age is higher, if the comorbidities are more, the death rate will be more. So from then onwards, it started saying the cutoff was earlier, it was 50. To start with, the definition of hypoglycemia according to ADA was anything around or less than 50 milligram of deciliter. Later on, it increased to 56, and now it is the 70 milligram per deciliter is the cutoff for ambulatory hypoglycemia, whereas severe hypoglycemia is less than 40 is defined as severe hypoglycemia. It's a very good question, Anandu. Whenever you want to try SGLT2 inhibitor, please not try. You please, if it is contraindicated, otherwise you have to start this SGLT2 inhibitors, and if the patient is on sulfonylurea, like glimepiride is taking 2 milligram, come down to 1 milligram or 0.5. If the patient is on 4 milligram, you come down to either 1 milligram or 2 milligram. Still the patient says hypo, you stop that, that's all. Let it be gliclazide, let it be glimepiride. These are the two drugs, the modern sulfonylureas, which have got the less incidence of the hypoglycemia when compared to the earlier, like glibenclamide and the glipizide. But still, I advise to reduce or to stop sulfonylureas and switch over to the combination of SGLT2 plus this particular DPP4 inhibitor to metformin. Or when you want to initiate insulin, you take off sulfonylurea and everything, and along with the DPP4 also, you reduce the dose of go with the lowest units of the insulin. If at all you are starting basal, let it be 10 units per day. That's all. So any questions? So you can unmute and ask me. Rangarajan sir, you are there, I think. So if there are no questions, I think.
Sir, can you hear me?
Yeah, yes, yeah. Sir, nice to see you first of all.
I have posted a question, but
No, it is not in the chat box. It is not in the chat box.
no, actually, I posted a question at the time of you starting the meeting.
Acha, what was the question, sir? Can you just read out? I'll just, okay.
You know,
Anyway, you have unmuted yourself. Please ask me the question, sir.
yeah. So the patient is 39 years old.
Patient is
39 years old.
39 years old.
39 years old.
39, okay.
BMI is 28. Weight is 80 kilos.
Okay, male or female?
Male, sir,
Male,
male.
BMI is 28.
Yes,
Weight is 80 kilos.
waist is 100 centimeters.
Okay, what is the BMI? 28, right? Okay, fine. 28 is okay.
Yes, sir.
Definitely, according to Indian standards, it is grade 1 obese.
Yes, sir.
Anything above 27.5 is grade 1 obese for us. Okay,
Yes, sir. The HbA1c is 6.3.
excellent.
He's not a smoker. He's not a smoker, not an alcoholic, no BP, and he has got no cardiovascular renal problems.
Oh, wonderful.
Diagnosed. So this patient is 6.3.
Yeah,
The question is whether this patient is, I have advised him lifestyle modification, I have advised him to go in for diet and exercise.
what is the A1C? 6.3.
6.3.
Okay.
The question is,
Ah.
I know very well, DAPA is not indicated for IGT because we see
Absolutely. You cannot initiate it in the stage of IGT. Definitely, metformin is the only drug of choice for IGT.
Yes, yes, sir.
So he is not on any drugs.
No, yes, he's not on any drugs.
So you have put him on lifestyle modification first.
Sir, just give me 2 minutes. Sir.
Yeah, please.
Sir, the thing is, see, it's well proven beyond doubt at the time of diagnosis, 50% of the beta cells is lost,
Yeah,
80% function is lost at the time of diagnosis. You see many patients with diabetic retinopathy or early stage of kidney problem. So, why, my question is, you don't know yet which point of time, at what point in time, is 6.3 will jump to 6.4 and 6.5.
yeah.
Once it crosses 6.4, he is a bad take. Now,
Yeah,
the
wha-
question is,
yeah.
international bodies cannot it, but my question is very simple. Why not you start them on SGLT2 inhibitors at this 6.3 stage of diabetes off-label? I'm not telling off-label.
Yeah, see, sir, see, what was the fasting and post lunch initially when the A1C was 6.3? Because A1C, you can A1C, yeah, just listen to me for a couple of minutes, then ask me. As far as A1C is concerned, it is just because of Professor David Nathan. Otherwise, it would not have been in the diagnostic criteria of type 2 diabetes at all. So, David Nathan is the nasty person who forcibly introduced this as a parameter, diagnostic parameter. Like he said, anything below the 5.7 is normal. Anything in between 5.7 to 6.4 is pre-diabetes, and 6.5 and above is diabetes, he said. That was in Philadelphia, actually. I was there physically. I was also one of the principal investigators for that particular, the making of the consensus as A1C. But the ADA always says Don't go by A1C. Even the A1C is 6.5 or 7%. Look at the fasting and post lunch. If they are high, then only start treatment. That's what it says.
Yes, I agree with you, sir.
Sir, can you tell me the fasting and post lunch sugars for that particular patient?
The fasting blood sugar is about 135.
Acha.
Blood sugar is about 135, and postprandial blood sugar is 170.
See, absolutely, he is a diabetic. Where is the question of pre-diabetes here, sir? The cutoff point is 125. That's all. Fasting is 126. It is 135 here.
Agree, sir. I agree with you.
So he first of all he is not in pre-diabetes. He's over to type 2 diabetes first of all.
Sir,
So you can happily start this particular combination because he is grade 1 obese. Though kidney and heart are perfectly all right, you can start the combination of this particular metformin to this particular SGLT2 inhibitor. He is the ideal candidate.
sir, I agree, sir. But, sir, let us say hypothetically,
Yeah.
suppose his fasting blood sugar is 110, and
Yeah.
his postprandial blood sugar is 170,
Yeah.
he still comes under IGT because
Yeah, he that is, see, absolutely. But to say that he is in IGT, you have to perform an OGTT. Then only you can say the patient is in between 140 and 199 just with a we have capillary blood glucose or the venous plasma glucose. You can never label a patient IGT. IFG you can always do fasting, but IGT has to be done only diagnosed. You can use that term only when you use 75 grams of anhydrous glucose and the reading is after 2 hours only. You can say that it is IGT. Why we particularly say every time try to screen in the IGT level, because the incidence of the cardiovascular events are similar along at par with the type 2 diabetes, and we find this similar incidence in IGT. That is the greatest disadvantage of IGT. And
sir, another one more point. Yeah.
yeah, so you have to start metformin, sir. Inevitably, metformin is the first drug of choice for that. And nowadays, that's what I said, hit early, hit hard wins. So, along with metformin, you please put one SGLT2 inhibitor which takes care of his weight also, which takes care of his the everything, all the metabolic parameters.
So, the question is, will you recommend SGLT2 in a pre-diabetic range, sir?
See, off-label recommendation is there, sir, but not a open label recommendation. It's only off-label.
Yes, agree, sir.
And one more thing, sir. One more thing. Even off-label also, it should not be used as an anti-obesity drug, sir. Some are misutilizing. My sincere request to my professional colleagues: never ever use this SGLT2 inhibitors as slimming agents, like orlistat, like liraglutide, like semaglutide, like phentermine and topiramate. So like that, please don't use that.
I agree with you, sir. Now, the next question is, sir.
Yes.
Newly diagnosed type 2 diabetes.
Okay.
HbA1c is 7.1.
Okay.
And the fasting blood sugar is 140.
Okay.
And the postprandial blood sugar is 210.
Okay.
Okay. Newly diagnosed.
Yes.
The question is, for this patient who's having a normal weight, normal BMI somewhere about 23.8 or 20, less than 24.
Oh, good. For an Indian, less than 24 is good, but okay, 23.5, okay, plus or minus 0.5 doesn't make any difference, okay.
Now his age is 40. His BP is normal.
Okay.
The question is,
Yeah.
whether will you like to start this patient on sulfonylureas, or would you like to start this patient on Sitagliptin plus Dapagliflozin take into consideration, not obese.
Okay.
When you like to put this combination, when you like to put this combination of this patient who is having a normal BMI and a normal weight, a
See.
normal waist circumference.
Say, yeah. See, it's a wonderful genuine question, sir. So unless otherwise it is proven otherwise like monogenic diabetes MODI, you cannot go for sulfonylurea. First of all. Second thing is, though he is not obese, though he is not overweight, still the A1C is 7, irrespective of baseline A1C, irrespective of the baseline the body weight, the patient, you can definitely use metformin and the SGLT2 in this particular patient, sir. See, that's what the evidence-based medicine says. Don't look at the A1C at all. Even it is 6.3 and the patient, you feel that he requires not for the weight reduction, to protect his the heart, to protect his kidney, to protect his the liver, you have to make use of without any second thought. If there is no contraindication for this particular the metformin and the SGLT2, more or less the EGFR is cutoff is same for metformin and SGLT2, sir. So you can happily start a combination of metformin SR along with this particular the dapagliflozin, sir.
So, do you think that dapagliflozin will reduce the weight in a normal person, sir?
No, it will not, sir. I have seen it in my clinical practice. Normal persons will never lose anything. And the second subset is the patients who are suffering from hypothyroidism, who have put on weight because of hypothyroidism, they never come back to normalcy when the thyroid becomes normal. Even the euthyroid state cannot get them to normalcy. At the same time, the SGLT2 inhibitor definitely will not reduce the weight in the presence of hypothyroidism, sir. These are the two conditions. Normal weight will never go back to this underweight or something else, and the patient suffering from hypothyroidism, whatever you use, they will not lose even a single kilo with the dapagliflozin or the empagliflozin, sir. So weight is not at all a barrier for initiation of SGLT2 inhibitors. Likewise, the baseline HbA1c is not at all a criteria for the initiation of the SGLT2 inhibitor. The only disadvantage with SGLT2 inhibitor we find is the increased LDL-C, which is mostly undesirable, sir. But when you weigh the cost benefit ratio and all, the scores over anything, and it stands in the first line, sir. DPP4 inhibitors, sorry, SGLT2 inhibitors.
So, now the next question is,
After metformin, sir, I always say after metformin, unless otherwise the patient is contraindicated for metformin.
sir, in your clinical practice,
Yeah.
where will you like to place sulfonylureas with the initial treatments? Because the cost has come down. My question is, where will you like to place sulfonylureas as an initial drug of choice in which group of patients?
See, first thing will be like see, even the lean type 2 diabetes, you have to start with metformin only, sir. Lean type 2, that's what. See, anything above 18.5 kilograms per meter square of BMI is an indication for initiation of metformin. So that is called typically lean type 2 diabetes. Lean type 2 diabetes also, you have to go for metformin unless otherwise this is contraindicated.
Agree, sir. My question is, where would you like to put the patient on sulfonylureas?
Sir, role of sulfonylureas in a newly diagnosed patient, you want to say?
Yes, sir. I want to know. Because do you think that sulfonylureas are dying?
See, yeah, sir. No, sir. I'll tell you. Yeah, now I got your question. First of all, see, along with metformin, a non-affordable patient comes with this particular scenario, I would like to go for very low dose of secretagogue like 0.5 milligram of glimepiride with 1000 milligram of metformin or 500 milligram of metformin. See, whatever be the recommendations, Indian scenario, you can never practice without using a sulfonylurea.
Sir, agree, sir.
This is
Yes, sir. But of late,
ah.
the cost of sulfonylurea is equal or little bit higher than the conventional.
Acha, yeah, you mean to say the half patented this Vildagliptin and Sitagliptin, half patented Dapagliflozin.
Yes, it's less than 30.
So see, sir, see one thing I would like to stress every time is whenever you use sulfonylurea, it eventually leads to pancreatic bankruptcy, sir, 100%. So it's better you don't go for this particular sulfonylurea. First choice is metformin and add DPP4 inhibitor and the SGLT2 inhibitor to metformin, sir. That's what I've been telling. The triple drug combination nowadays. Triple drug combination means in diabetes, triple drug is metformin, SGLT2 and DPP4 combination is the triple drug. Never ever like earlier days, we used to say a sulfonylurea, metformin and a glitazone was triple drug. And later on, when pioglitazone went off for a short while, the pharma industry has made the wrong combination with voglibose and metformin and sulfonylurea. This is absurdity, sir. Probably, if you believe me, honestly, I'm telling you, I'm the only one doctor who have never generated a prescription for this particular Dapagliflozin and never prescription for voglibose, metformin and glimepiride combination also. Because each has got a different time, sir. It's irrational to combine all three in one pill, where the alpha glucosidase inhibitor has to be taken after the first bite of the food. So when do you take that? After food or before food? The glimepiride half an hour before breakfast or food. And the metformin, you can give it any time, because even metformin also we generally give, I generally give the combinations even prior to breakfast only. But because of the GI intolerance, I ask the patient to take after the breakfast, sir. If at all the patient says some sort of metformin GI intolerance is there, I do go with the low dose. I slowly increase, and when the patient is okay, and that too I put it separate after breakfast and after dinner.
Sir, I totally agree with you. I come under your category because I don't have any. I last time gave this glucose after the food or before food. After the first bite you should take, sir.
Yeah, you see, they just wanted to highlight it as a triple drug, and meanwhile, pioglitazone came back actually.
Why? Because now they are trying to promote the point.
Sir, in this context, I'll tell you the three-pronged approach to stop the cardiovascular disease. Only cardiovascular disease, sir. I'm telling you, cardiovascular disease includes only the myocardial infarction and the stroke. That's all. Heart failure is not included in CVD. Cardiovascular disease is totally different. Heart failure is totally different. If at all you want to be give a successful and a beautiful prescription for that particular patient, a triple drug combination of SGLT2 inhibitor, DPP4 inhibitor and a pioglitazone is the best triple drug for that particular patient in the absence of HF and in the absence of the volume overloaded state, sir. That's what. So everybody is scared of pioglitazone. There is no need to get scared of pioglitazone. Even the latest, the 1 month ago, the research article was published saying that the patients who are on pioglitazone are at reduced risk of cancers by 40%. All cancers.
Plus, even metformin has got the same effects. Metformin also,
And see, I told you the pleiotropic drug is metformin, next is statin, next is SGLT2, sir.
I totally agree with you, sir.
See, only the problem with the pioglitazone is it increases the weight and the visceral fat is converted to subcutaneous fat. So pedal edema, the puffiness, and this and all, and the anemia is one more side effect of this thing, and the bones become fragile and they are more prone to the fractures, sir, actually. So apart from this, if you select an ideal candidate for pioglitazone is going to do wonders.
Sir, the amount of pioglitazone which is being given in USA is 45.
Yes, sir. They go to the maximal dose, but
Yes, sir.
there is only one condition, sir, where you have to go for the maximal dose is where the patient has got the non-alcoholic the fatty liver disease or non-alcoholic steatohepatitis. That is the only one condition where 7.5, 15, 30 are useless. Only 45 is proven to be efficacious, sir. Along with metformin, but still I tell you, along with metformin, pioglitazone has become the number one drug of choice for the NASH and the NAFLD. So along with pioglitazone, you have to use metformin, you have to use SGLT2 inhibitors, you have to use DPP4 inhibitors, you have to use statins, you have to use the lipaglyn, what is saroglitazar, you have to use fibrates, you have to use vitamin E in the dose of 400 milligrams BD. So this is a multi-pronged approach. Along with on top of it, anything and everything, sir. Diet and exercise, reduction of weight, cessation of smoking, cessation of alcohol is much preferred. Without that, any drug would be useless, sir.
I agree with you, sir. Sir, another one more thing, sir, I would like to bring to the highlight.
Yeah, please.
Sir, you said to diagnose diabetes, you have to give a glucose challenge.
No, I never said that. I never said that, sir. I told you want to use the term impaired glucose tolerance.
No, sir, for diagnosis of diabetes, how will you go about it, sir?
Yes, see, in only unequivocal cases you go for OGTT. OGTT is not a the routine test. It is not recommended at all, sir. All the international bodies, they condemn doing OGTT for each and every case. It is not at all required, sir. The simplest is the fasting, but to be repeated on 2 different days. That is enough, sir. Anything around or above 126 is diagnostic of type 2 diabetes.
So, the first application is the post-chronic blood sugar rather than the fasting.
Yeah, see, that is, see, when you come to the simplicity, as per the recommendations of American Diabetes Association, you want to be cost effective, only fasting will do, on but 2 different days. You cannot rely on a single day reading, fasting.
So, still you do you advise your HbA1c apart from fasting on 2 different days?
Never. The pathetic part is unless all the laboratories in the world are standardized to this particular the DCCT assay, you cannot routinely say that 6.7 of A1C is diabetes. You can write the type 2 diabetes by A1C. But treatment always depends on the fasting and postprandial blood glucose only.
HbA1c has got not much of relevance in your perspective, sir.
HbA1c?
In your, it's not in your view, it's not a very promising.
Definitely, sir. It has got two greatest disadvantages, sir. The first disadvantage is it never gives you a clue about hypoglycemia and hyperglycemia, sir. First of all, I am talking only evidence-based medicine. Second thing is it doesn't give you any idea about glycemic variability, sir.
I agree, sir. I'm talking about in the diagnosis of type 2 diabetes.
As far as diagnosis is concerned, you can make a diagnosis. Certainly by A1C, if it is standardized to DCCT, that's what. If the laboratory, the A1C apparatus you are using should be standardized to DCCT assay.
That I agree with you, sir.
Because what has happened, the same, we were all opposing, everybody opposed. The 20 panel members, I was one among the panel members. We strongly opposed. Only one person who said is the committee chairman David Nathan, 2012 Philadelphia ADA sessions. He said it should be included. It was seconded by Vivian Fonseca. So he is a Goan by his origin. Indian, Vivian Fonseca. He works in this particular Tulane University, New Orleans, Tulane University. So, but for these two persons, all 18 opposed to include it as to incorporate. Already we have got sufficient diagnostic criteria, sir. First thing is fasting, done on 2 separate days. Anything above 126, 126 or above, label it as diabetes. Second thing is you have got the random blood glucose. So any time of the day except fasting, if it crosses 200, but should be associated with symptoms of diabetes, sir. Symptomatic diabetes, either you must have polyuria, polydipsia, polyphasia or unexplained weight loss. One single reading, if it is 200 with a symptom, you label it as that. And third thing is 2 hour post glucose, which is where it is unequivocal, the readings where you cannot conclude or exclude diabetes, then go for that. It is not a routine procedure. OGTT can never be a routine procedure for type 2 diabetes, but that is a valuable procedure in GDM, sir, actually. GDM you have to go by, you have to go by that, and GDM also I always try to give a message to everybody that don't wait for they said 24, 28 weeks and all. See, just initial first antenatal checkup itself, you get it done. You can catch it up, sir. So sometimes, see, the pre-GDM category is fallacious. Sometimes the patient might be having type 2 diabetes of milder degree, but not diagnosed. But after pregnancy routine checkup, it is like diagnosed like 220, some random blood sugar. So first antenatal checkup itself, along with thyroid, this must be a mandatory indication, sir. You must order along with the other investigations. What you order, the blood sugars must be included, and the OGTT is all the time the most preferred one, sir. Either the one-step approach or the two-step approach, whatever it may be, depending upon the motivation of the patient, economical status of the patient. So that is totally different, sir. Giving 50 grams of this thing and giving 100 grams of glucose OGTT. Yeah, that is, sir, our DIPSI guidelines are totally different, sir. It is 75. I am talking about the American Diabetes Association, that is the that is what is called the Carpenter and Couston modified, sir. I am telling you that particular this thing.
I agree with you totally, sir. But my humble request is, we are in Southeast Asia, we are in India.
Yeah.
Let us talk something which is pertaining to Indian subcontinent. not-
Yes, I am. See, sir. Even the body weight also, the BMI also, I never follow the Western scenario. We have cutoff points. See, Indian guidelines are totally different. They exactly fit into our curriculum. See, the cutoff is 23.5. It is 23.5. Anything above is overweight. That's all. Anything below 23.5 is normal. And even the exercise also, sir. There is a lot of difference between the Western recommendations and the Indian recommendations. We all the time advise 60 minutes of brisk walking or something else. But the Western scenario, they say 150 minutes a week. That is, you do it on 5 days, 30 minutes. You take holiday for 2 days. But I never ask the patient to take holiday unless otherwise he or she falls sick. Sick day, I ask them to take rest. But for that, it's raining cats and dogs. Okay, I ask them. So if you have anything indoor like the static cycle or the treadmill, you can go, but not on routine basis. I always advise them to go to a stadium or where you find a lot of people. You get motivation there. Indoor exercises are only for the VIPs or the politicians or the film actors who need some privacy, sir. That's all.
Agree, sir. Sir, another one more question. Why would you like to place, say, Dapagliflozin 5 milligrams?
Pardon, sir?
5 milligrams of Dapagliflozin. 5 milligrams.
Sir, Dapagliflozin 5 milligram doesn't serve any purpose, sir. Because all the studies are done with, starting from Diclofenac 58 to this particular DAPA HF and the DAPA CKD and the deliver were done with 10 milligram of Dapagliflozin, and the Empagliflozin also was done with only 25, sir, never 10. And of late our doctors thinking that it is costly, the Empagliflozin, they are making the 25 into half, 12.5, and the advising the patients to take that. I am against that, sir. You are not supposed to. You are not supposed to cut the tablet and take. Yeah. If you strictly go by evidence-based medicine, even our country also, we did trials on this SGLT2. It is multi-center randomized controlled studies, sir. All the studies done with SGLT2, all the COOTs, they have the Indian population, sir.
Sir, I agree with you as the guidelines, it's only 25. The difference between 10 milligrams and 25 milligrams, the benefit you get only 6%.
Yeah, that's what I am telling, sir.
20. You won't get any great benefit between 10 and 20, only 6% of benefit you will get. That is very, very, very cruel beyond doubt.
So, but no trial was done with 10 milligram of Empagliflozin and 5 milligram of Dapagliflozin, sir, and 100 milligrams of Canagliflozin. All the trials were done with the maximal dose.
But why is the company has come out with 10 milligrams of Dapagliflozin, 5 milligrams of Dapagliflozin?
See, maybe for Indian population where the BMI is low, where they cannot tolerate the high dose of this thing, you can go for 5 milligrams, sir. That is the intention of the pharmaceutical industry, that's all. They want to have two strengths every time.
Sir,
And it doesn't mean that, see one more point, sir. I would like to make it very clear that, okay, the DAPA CKD included the EGFR from 25 to 75. It doesn't mean that you can use 5 milligram below 30 ml of EGFR, sir. You can never use.
You can never use it.
You can never use, sir.
Totally agree.
See, this is all pharma gimmicks, sir. 5 milligram of Dapagliflozin, pharma industry gimmicks, sir. 10 milligram of Dapagliflozin, nothing. There is no study at all, sir. All these studies, we were the principal investigators. Several Indians were the principal investigators, and thousands of people were enrolled from our country only. So it is not only one single trial like this Covishield that was done by Oxford researchers with the help of our scientists from Serum Institute of India. The phase 3 clinical trials were done in UK only. So this is not so with this particular SGLT2 or DPP4. Everybody took part. All parts of globe were incorporated, sir.
So, in the earlier years, people were using 50 milligrams of Sitagliptin. I don't know why. Because the efficacy is not that of 100.
Sir, I told you in my lecture that it is only 100 milligram that gives you so much of reduction.
Benefit.
So only 50-25 is to down titrate in cases of kidney disease, sir. With impaired renal function, you can come down to, if it is below 45, you have to come down from 100 to 50, and if it is below 40 and it is nearing 30, you have to come down to 25, sir.
That I agree with you.
Only this down titration is required in the renally impaired patients, sir.
Yes, sir. Lina can go up to any amount of EGFR.
Yeah, Lina, I always tell everybody, in every speaker program I tell, linagliptin is the real renal gliptin, sir, that's all.
I agree with you. Totally, sir. Totally.
Along with insulin, sir, along with insulin. I never say alone, that will not serve the purpose, sir. So without insulin, linagliptin becomes useless, virtually useless.
It's not a very powerful molecule, but only thing is now Lina also has come out of
You see, that is very much indicated. The beautiful aspect of this particular linagliptin is that can be used at any EGFR, ESRD, and dialysis, even the transplant, even the post-transplant, new onset of diabetes. It is the drug of choice, sir. Apart from insulin, sir. Apart from insulin, I am telling you.
I think it's one of the very good molecule in for NASH also, sir. NASH.
Yeah. That's what yes.
Now the cost of Leela is come down to 30 to 15 rupees. Now it is
No, sir, it is, no, sir, it is pending in the court actually. These people have patent rights. No, MacLeod, see, I'll tell you, sir, I'm a medical advisor to Boehringer Ingelheim. I'm telling you the facts. The first of all, MacLeod's people are sued, Micro people are sued.
brought out.
It is in the market, sir. It is in the market actually. The companies, the three companies who have manufactured this particular, the linagliptin is MacLeod's, Micro, and the Aries. They stopped promoting it because they received all the legal notices. Now the court is, the case is pending in the Supreme Court of India, sir.
But it is available in the market.
It is available, sir. See, one thing, sir, take it in a lighter vein. India is such a country that you can do any undo things in our country, sir. See, before the patent rights end, how can they get a molecule in such a erratic way, sir? It is something like violating the traffic signals and paying the challan. See, Vildagliptin After the patent rights were over, the next day only they launched. The Sitagliptin, after the next day only it was launched. And Dapagliflozin, after the next day only it was launched. What all the other companies did is pre-launch marketing they have done, sir. Pre-launch propaganda they have done, but straight away violating the patent rights, the MacLeods, Aries and Micro people have deliberately had marketed this linagliptin, sir. And now that they are paying for that, the Supreme Court of India, they are paying for that. That's all. But soon it's going to be off patented, sir. Linagliptin also will be off patented.
Sir, another one more question, sir.
Yes, sir.
Do you think the originator molecule, like Sitagliptin, like Genuvia,
Sir.
whether that is the bioequivalent,
Ah.
equal to that of the newer what is being brought up with other companies?
The generics, what you say.
Yes, generics.
Sir. Yeah.
Or whether it is inferior.
Sir, you can never compare the generics with this. These are biosimilars, that's all. The original molecule is original, sir. And one more thing, the couple of months ago, US FDA has imposed a ban on Genuvia because they carcinogens were traced out in Genuvia. They immediately they took off the batch and all. The US FDA imposed a ban, sir.
That was in only in USA, sir.
That was a big blow for the MSD people.
It's a big blow, sir. That I agree with this.
Sir, even coming to the insulins, I am telling you, sir, even insulins, nothing can compete the Novo Nordisk, the Eli Lilly, sir. Others are all biosimilars.
I agree.
Even taking Dapagliflozin, Empaglif, whatever it may be, sir, whatever the molecule that comes like in a generic form after the patency is over, they see there is some 98 to 99% of bioavailability, sir, when compared to that, but not 100%, sir. Original is always original, sir.
Agree, sir. Agree.
Because Genuvia and Istavel are the manufactured in Switzerland, sir. MSD is based at Switzerland. The company sends the Sitagliptin molecule all over the world from Switzerland only, sir. Till today, sir. Till today.
So now Istavel is come up with their own products.
Yeah, I am talking about only MSD, sir. I am talking about only MSD Genuvia. Istavel has become free, sir. Now they are not in the clutches of MSD. So now that the first company to come out is Istavel, that is Istamate XRD. That's what the 100 milligram of Sitagliptin, the 10 milligram of Dapagliflozin, with 1000 milligram of the sustained release metformin. They are the first ones to release, sir. It is only 19, less than 20 rupees, sir.
Less than 20.
It is 19 rupees, sir. 19 rupees.
Yes.
So we should encourage the triple drug, sir, from a good company like Sun, like the USV, like Lupin and all. They're all doing well, sir. Even the quality of Reddy's is very good, sir. As far as the Dapagliflozin is concerned, I have seen, sir.
So now today the new launch of Sita 100 and Dapa 10 metformin extended release 500 has come into the market today. It is costing 19 rupees 50 paisa. Sorry, 18 rupees 50 paisa.
Which company, sir?
Sun company. By Sun company.
Yeah, Sun. That's what, sir. Sir, it has only one. I'm telling you, it is estimate XRD, sir.
No. This combination, talking about the metformin combination, does not come out in Istavel or Istamet. Now the company is another company wherein they have got. See, some people have got so many branches.
Sir, see, one division is promoting Sitagliptin plus Dapagliflozin. Another division is the original Histavel people. They have come out with Histamet XR, that is 1000 milligram of metformin, 100 milligram of Sitagliptin, 10 milligram of Dapagliflozin, sir. That is 19 rupees, sir.
Sir, today the three drug molecules coming to the market with metformin extended release 500 milligrams.
Sir, nowadays, in the days to come, we find triple drugs with Vildagliptin and Sitagliptin like anything, sir.
Sir, I think so. You cannot compare head to head with Vilda with the Sita, sir. I feel Sita is much better than Vilda.
Sita is definitely much better than Vilda, sir. I always told you. See, the COVT, the Vildagliptin has no COVT, has a different story, sir. Just 2 minutes, I'll tell you. The first DPP4 that rolled out is Novartis Vildagliptin. And second point is the gliptin term was introduced by this particular the Novartis along with WHO. Third thing is they just entered into US market. They asked, that was the first DPP4 inhibitor in the world. When they asked, it said you have to submit me some COVTs. By the time they did COVTs, the next year itself Sitagliptin was approved. Without any COVT. Later on they submitted TECO, sir. See, it is all politics, sir. Lobbying, US FDA is known for lobbying, sir. Just because Novartis is from European Union and Merck is American based. So it always supports American companies, sir. That's all.
Till now,
See, even Glargine, sir. I tell you, sir, the story of Glargine. See, way back in long time ago, everybody started saying this particular Glargine is carcinogenic. Until then, nobody asked any COVT. Then the US FDA said we need COVT. Then they did origin trial, sir. I was one of the principal investigators in that particular origin trial, sir. And one more, my friend, Dr. Shanmugavelu is there in Coimbatore. He was the another principal investigator for that origin. We did it for 7 years, sir, actually. After 7 years, they concluded that it is not carcinogenic. See, I tell you in this context, sir, smoking also. It takes 20 years to develop lung cancer, sir. Or bladder cancer, or whatever it may be. Any oropharyngeal cancer, whatever it may be. See, if I say after 10 years, tobacco did not produce any cancer, so that is childish, sir. So even likewise, origin trial, doing for 7 years, and after 10 years, maybe after 20 years, maybe, all the time, the question mark will be there, sir. All the insulins, not only to Glargine, any insulin can be like carcinogen, sir, because it is an anabolic hormone. It helps the cell to replicate very fast. Only thing is the other proliferation is the typical proliferation, whereas the malignant cells are atypical proliferation. That's all.
agree, sir. Agree, sir.
So it looks very funny if I say after 7 years, I have consumed tobacco for 7 years, I did not develop lung cancer, no oral cancer, no oropharyngeal cancer, nothing. So tobacco is not cancer, doesn't contain any carcinogens. Is there any fact in that the statement, sir? Likewise, origin also, 7 years, it was proven to be non-carcinogenic. And after 10 years, what happens? Who knows what happens, sir? Nowadays, the cancers are on the rise, sir. Just because of smoking and alcohol, the cancers are on rise. So the same issue went on with metformin also. Metformin, several brands were banned in US. Top 5 companies were banned, sir. Because they found some carcinogens in that metformin. NDMA was there.
Recording in progress.
Sir, any questions?
Sir, metformin USA, sir?
Metformin actually, sir, finding this particular the carcinogens, especially in the extended release, sir, ER, XR and all. It has banned all the metformin, except the plain preparations. All were banned, sir.
Even now,
Till today, sir, till today. Even lupin has was banned, sir. Lupin, the gluconam was there. It was also banned.
sir, we have news to me, sir. Okay, sir. Okay.
Sir, if you look at the latest updates, you will be shocked, sir. You will be puzzled, you will be shocked. One fellow says if you take tea, the heart attack goes down by 27%. The second day, the second fellow says if you take coffee, it reduces by 37%. What to believe, what not to believe is $1 million question. One fellow says if you drink tea 3 times, that's going to reduce your the incidence of dementia, he says. And the same other group says if you drink coffee, the incidence of dementia is reduced. This is how it's going on, sir.
Sir, I don't know what to believe, what not to
Yeah, what to believe, what not to believe is $1 million question. So let us use our brains, sir. That's all.
You are very good, sir.
Let us use our brains. Let us use our stethoscope, sir, rather than totally depending on the investigations. There is a matter in between 2 years. Let us use that matter, sir. That's all.
Sir, I agree with it totally. Sir, don't be carried away by all these things.
Yeah, that's what. See, I told you in the beginning itself, sir. Companies will say, use this molecule in this condition, that condition, this condition. But when not to use, they'll never say, sir.
They will never tell the side effects.
They'll never tell the side effects. That's what. See, in my every speaker program, I just try to tell them where it should not be used. What are the side effects, first of all? Where it is contraindicated. See, you must know the contraindications before the indications, sir, first of all. Then only you will be a professional driver.
Sir, I've been telling this for so many years, sir. I used to tell them, you first tell me the contraindication, tell me the side effect.
Yeah, tell me the side effect, contraindications and the adverse reactions, major adverse reactions and MACE also. Major cardiovascular events also, they will not highlight, sir.
Sir, another most important thing is drug-to-drug interaction is very, very important, which no one knows about it.
That's what, sir.
I say that.
That's what. Drug-to-drug interactions. So many drug-to-drug interactions are there. See, before prescribing any molecule, one should have sufficient knowledge about that molecule, sir, first of all. Until then, you are not supposed to generate a prescription, sir. It is not on trial and error basis one should generate, sir. It is with the sound knowledge where it is to be used, where it should not be used. You should be knowing the common side effects. Sir, SGLT2, the common side effect is running nose, sir, URI. The patient comes with URI and the doctor says nothing to worry, take some. So without any hesitation, they are writing antibiotics for the simple rhinitis, sir, allergic rhinitis.
Agree, sir. Sir, another one more point I would like to highlight, sir.
Yes, sir.
People who are having
Yes.
And when they become bigger, when they still become older, and if you put the patient on DPP4 inhibitors, the rhinitis precipitated. I don't know whether you saw this article.
I saw this. It's absolutely, yes, I saw. I went through the article, sir.
So it's better you have to find out because you get some rhinitis, this rhinitis following DPP4, it's not at all.
You cannot simply say that DPP4 induced rhinitis, SGLT2 induced rhinitis. You cannot take it so light, sir.
So recently there was a few cases seen by one of my friend using SGLT2 inhibitors. The 3 people developed urinary tract infection. Adults, males, not female.
See, sir. See, if it is with the adults with a short urethra of only 4 centimeters, how females will tolerate that?
Sir, not females. I'm talking about males.
Yeah, that's what, sir. See, when males are affected,
About,
what about females? I am telling you, sir.
that is what?
With a very short urethra, the ascending infections are more in females.
Common, sir. Sir, but I'm talking about males. 3 males they have found to have urinary tract infection following the DPP4. I'm sorry.
SGLT2. We need to
Dapagliflozin.
stop it immediately. And even the preoperative and postoperative also, it is not the drug of choice, sir. Never use SGLT2 after this thing. And once the patient lands up in euglycemic decay, stop the drug for at least 10 days, sir.
Agree, sir.
Until it is, even though the patient is discharged, you are not supposed to start after 10 days. Before 10 days, sir.
So if you want to put the DPP4 in the elderly people, make sure you are not missing an enlarged prostate and retention.
Absolutely. Absolutely, sir.
That's very important. Very important.
That's what.
You have to find out all these things in the history, sir.
Yeah, that's what, sir. That's what. Just see, before putting any DPP4 inhibitor, just ask the patient about the past history of pancreatitis. At least clinical pancreatitis, whether he had stomachache with vomitings and all. This is clinical pancreatitis. And biochemical pancreatitis, okay, with the grossly elevated lipase and amylase, that and all is a secondary one, sir. High triglycerides.
How does, sir, how does DPP4 induces pancreatitis in a already old pancreatic patient? What is the relation between causing pancreatitis by DPP4 in a old pancreatic infection, sir?
Sir, I didn't get you. Repeat the.
Sir, you are telling old history of pancreatitis not to use DPP4. Okay, sir.
Are with documented cases of pancreatitis at least?
No, what happens? What happens? What is actually the pathophysiology, sir?
Sir, pathophysiology is still not understood behind the pancreatitis, but it is related to pancreatitis, sir. It may flare up. If it is a documented case of this thing, that is one of the contraindications for initiation of DPP4 inhibitors.
You mean to say it will flare up? But
Yeah, again it recurs, sir. The pancreatitis recurs.
No, I want to know what causes it.
That's what, sir. The pathology is not known. The mechanism is still that remains a secret. That's all.
Sir, one fine point you were told, sir, when you add DPP4 with SGLT2, the chance of urine increase comes down because
Little bit, sir. It is. I have observed, sir. Combinations. The people have. That's what, sir. Because of the DPP4 inhibition, it comes down.
because in the same what is called inhibitors is found to rest in the fungi.
That's what, sir. That's what. So combination is always better than single usage of SGLT2, sir. And that too, we are getting it in a very affordable price, sir, nowadays.
Sir, another one.
Sir,
You DPP4 separately. You give DPP and SGLT separately. This affects, sir.
100%, sir. 100% effective.
No, sir. I'm not asking you if you give separately.
Says most of the times it so happens, sir. la- Earlier patients, I might have put them on Istavel or Januvia, sir. So later on they come to me. I cannot write a combination for them. I would rather go for, today it has come, sir. Until yesterday I used to write Dapagliflozin separate.
Okay. Because the company people are claiming that combination acts much better.
Sir, FDC, that's what I talked about, sir. Sir, FDC always minimizes the polypharmacy, sir. See, our patients, it's something like a magic Pandora box they open, sir. It has got anti-diabetic drugs, it has got antihypertensives, it has got lipid lowering drugs, it has got thyroid, it has got this particular the other problems, antiplatelets, and the drugs for neuropathy. So many things it will be. So at least to minimize the polypharmacy, so at least to minimize for neuropathy, I write a combination of methylcobalamin plus pregabalin plus 10 milligram of nortriptyline 3 in 1, sir. That's all. So polypharmacy is a big problem for any patient, that too elderly patient with cognitive impairment, sir.
Agree, sir.
So to minimize polypharmacy, I encourage the FDC, sir. But FDCs, the only disadvantage is they have got a fixed dose. We cannot I want to go for less dose of this thing. I have to stop. See, if at all you want to go for 50 milligram or 25 milligram of sitagliptin where the kidney is compromised, you have to break the combination, then go for individualization. That's all.
Sir, that is only for limited cases.
Limited case, very limited, sir. Less than 1 to 2%. Another 98% of the population are benefited by the fixed drug dose combination, sir.
Totally agree, sir. I totally agree.
And the patient compliance also goes down, sir. If there are too many pills, the patient compliance and the tolerance that they go down drastically, sir. They take missing, they take morning, they take, they miss nighttime vildagliptin, sir. Suppose, as an example, I am telling you.
Agree, sir. Agree.
If it is 100 milligram SR, at least they take it in the morning enough. They are not going to miss a pill.
Sir, the medicine is a science, but practice is an art.
Sir, medicine, that's what I conclude by saying medicine is a science as well as an art, sir.
So practice is an art, sir.
Yeah, practice is absolutely the art that comes out of experience. And one more thing, sir, one size doesn't fit all. That is every time I tell, sir.
That is quite true, sir.
If I'm not wrong, one size doesn't fit all, sir.
Totally agree, sir. I don't deny at all. I take your statement as a good.
Sir, your presence always makes the session very dynamic because of your questions. You always try to enlighten the participants, that's all. So, very nice to see in my speaker program, sir. I always look for Rangarajan, sir. Is he there or not?
Sir, your presentation is beautifully done, sir. Because you go everything step by step, and what are the practical implications at that point of time, you highlighted apart from whatever is given in the in your slides.
Yes, sir. I go out of the box and I say, sir.
This is very.
So my urge is only one thing, sir. Let our professional colleagues be benefited by my talk at least. If they learn some 1 2 points, it's enough, sir. As a speaker, I'm happy,
Sir, let me tell you, sir.
sir.
See, this profession is not to make a quick money. If they want to make a quick money, there are so many other professions.
Yeah, they should. It is not their cup of tea, sir. They should go for some other profession.
Yes, this is totally. We have got
Service oriented, sir. Ours is service oriented.
And totally, sir. That is what I say, because it is something. It is
Yeah.
very divine.
That's what, sir.
And
I always say that treat with your heart, treat with your human touch.
sir,
Don't be just mechanical. I always say, sir. Always say
sir,
to my juniors. I always say, do justice to your profession first of all.
sir, let me tell you, sir. You people who are not attending your lecture, they are missing something in their life, sir.
Oh, sir. It's so kind of you, sir. Sir.
No. See, I would like to tell you, sir, my experience is not 1 year or 2 years.
Yes, sir.
I have got my experience for 50 years of experience.
I know, sir.
Okay. So, what I want to tell the youngsters is, raise up questions in the forum.
Yeah, that's what, sir. Don't hesitate to raise your questions. If you are hesitant, don't mention your name, but raise the question, sir. That's what.
No, I'm talking even not in the webinar, even in eye-to-eye contact. Raise up a question. That can be foolish. That can be something. But try to see, you raise up a question.
Sir, in my view, there is no small doubt and big doubt, sir. All doubts are doubts. That's all. It should be clarified.
Agree, sir. I totally agree with you, sir.
What you think it is a small, maybe a big problem for somebody else. See, out of shy, they don't ask the question, sir. What others think about me if I ask this silly question? See, they should come out of all this inhibition, sir, actually.
So the problem is still inhibition, ego,
Sir,
speaking fluently, then they have an inhibition.
you have totally broken the coconut now. Because as a speaker, I have some limitations. I can't go beyond that. But you're all free to say that, sir. Ego, you said absolutely, but I did not say that word, sir, because the due respects to all the professional colleagues. That's all. So anyway, thank you so much, sir. It's an honor for me that you are in my speaker program all the time, sir. That's it. You raise lot of questions in the interest of junior doctors, and so
Yes, sir.
that is.
I really,
You, sir, you are the only one who is so much interested, sir. That's what. The enthusiasm, the curiosity, and the knowledge. See, if you don't update, sir, you will be lagging behind. You are gone.
totally, sir, totally.
No,
When
no.
I go retire,
Knowledge is never poison, sir. Even you take it in the higher doses also, there is no overdose.
sir, I would like to conclude by saying the laziest organ in the body. Do you know which organ, sir? Which is the laziest organ in the body?
Pancreas is the laziest organ according to the science.
Sorry, sir. Sorry. For your kind information, let me tell you, the laziest organ in the body is the brain. You know, because you keep on bombarding, then only your neurons will get activated.
Yes.
Otherwise, it will go on slumber.
Yeah, that is true, sir. Even when they tested Albert Einstein, who is supposed to be the most intelligent man on the earth, when they did all the studies, they recharging the neurons. So only 10% of his brain was used, sir. So what if another 90% was used by Einstein? What it would be, sir? You are absolutely right, sir. You are absolutely right. Yes. You should all the time sharpen your brain, sir. That's all.
You take a lawyer, he may be 80 years old, still he keeps on reading.
Yes, sir. Yes, sir.
Alzheimer's.
Yeah, every case, yes.
Alzheimer's. No Alzheimer's for him. No multi-infant dementia for him.
Absolutely right, sir. No personal dementia, no Alzheimer's, nothing.
Sir, my good wishes to you, sir.
Sir, thank you so much, sir. I am fortunate to have you in the.
Whenever you conduct a meeting,
Sir,
please inform me, sir.
absolutely, sir. Absolutely, sir. Absolutely.
It's only a request.
It's my privilege to have you in the this thing, sir.
Sir, you are in Andhra Pradesh, Kannur. I am in Tamil Nadu, Coimbatore, but still I love to join with you in updating myself from you, sir.
Sir, so that's so kind of you. You are so humble, down to earth personality. I know, sir. You know everything. In the interest of audience, you raise the questions. That's all I know, sir. Not that you don't know. You know the answer also. But still, in the interest of audience, who cannot ask me, maybe because of shy, maybe because of some other inhibitions, they cannot ask the question, sir. But you ask the question so that at least some myths we should shatter, sir. At least we should blast some misconceptions.
Yeah. Sir, I don't have any ego, sir.
Sir, I know that, sir. I know that, sir. I know that.
I don't have any, sir, my language is also plain. I don't have inhibition. I don't have any self-confidence.
Yes, sir. Yes, sir.
Any forum. Whether it is RSSD or
Whatever it may be, sir. Whatever it may be.
I don't mind, sir.
Yes.
Because at the end of the day, let others be benefited.
Yes, sir. Yes, sir.
It's very important. This is a subject every day, as you rightly said, 3 cups of coffee, 2 cups of tea,
Yes.
and lemon tea, to take a green tea, and all this rubbish, I don't know how far it's going to go. That's all.
Anyway, thank you so much, sir.
My good
You made this session very lively, sir.
Thank you, sir. Thank you for your kind comments, sir.
Right, sir. Good night, sir.
Thank you very much, sir. I think so.
Thank you, sir. Thank you for the wonderful session, sir. And special thanks to Rangarajan, sir.
Yeah. Rangarajan, sir, always makes the session lively. Yes.
Sir, I'm honestly saying, sir, I really, sir, I am having a part of, which is the wonderful session, sir. Scientifically, medically, and moreover,
Yes.
all technical knowledge.
Yes, Chaitanya, you are absolutely right. Sir is very knowledgeable, but in the interest of audience, he raises so many questions. That's all.
Thanks for the party.
So,
My honor, sir, having a part of so much of wonderful.
yeah, this is your maiden speaker program, I think, Chaitanya.
Sir, thank you, sir.
Thank you so much for your support, Chaitanya, and thanks to the technical team at the back end. So, shall we wind up this session?
Sure, sir.
Yes. And again, once again, thank you so much for patient listening to my fellow doctors. So, I sign off, Dr. Sepuri Krishna Mohan.